Why are older adults with HIV at increased risk for multimorbidities? Um, I think that we have most of the attendees log in by now. One moment.
Okay, I'm going to begin. Can I be heard? Just send me a text message to say yes. Great, thank you. Sorry for these delays, but we can blame it on Facebook or something like that. Anyhow, thanks again to NAC for inviting me again for this second presentation on HIV and aging. And my hat is off to NAC for recognizing this growing issue of HIV and aging and the ever-increasing number of older adults with HIV. Next slide, please. That's me. We don't have to go through my bio. I'm sure you can read it online. Let's go to the next slide, please. And the next. Okay. I'll try to speak louder. What I'd like to begin first to show you the numbers. This is New York City, which is the epicenter for HIV infection in North America. And as you can see in these bar graphs, that the number or percent of people living with HIV age 50 and older has steadily increased since the beginning or around 2000. And in New York City, at least, we're at about 57% over the age of 50. Next slide, please. This data is just recently published by the CDC, and it shows the number of people living with HIV, which is about 1.3 million in the USA. And if you look at the red bars, which are over 50, and actually if you look at the 40 plus, you'll see that actually almost 70% of the entire HIV population in the USA as of now are age 50 and age 40 and older. As many have said, the HIV and aging issue will dominate this epidemic as we move forward. Next slide, please. These are the percent of people living with HIV in selected cities across the USA. And you can see they're kind of all hovering around 50+%. The exception is San Francisco, where it is 64%. It makes sense since this was kind of the beginning, if you will, of the epidemic. Next slide, please. Within the population of older adults with HIV are the long-term survivors. There are not many estimates about what percent they are, but looking at New York City data based on about 120,000 people, the estimates that of all people living with HIV, about 26% are long-term survivors, namely those people who were diagnosed with HIV before 1996. And of all older adults, it's about 46 to 50%. Next slide, please. So as we move forward this afternoon, it's estimated that 70% of the HIV population will be age 50 and older by the end of this decade, or at least by the beginning of the next. Older adults with HIV more often succumb from non-AIDS related or non-HIV related illnesses. Multimorbidity, which is 2 or more clinical conditions, chronic conditions, is not the exception, but the rule in this population. And the management of multimorbidity in a person with HIV aging is the new challenge. Next slide, please. So a simple definition, multimorbidity occurs in a person has 2 or more chronic incurable conditions. For the person living with HIV, they already have one. All they need is a second one. It could be osteoporosis, cardiac issues, whatever, we'll see. But the number of people with multimorbidity is substantial in the HIV population. Next slide, please. Just to give you a sense about why the medical establishment, the healthcare providers are concerned about multimorbidity, there are 2. One, we live in an aging society for the first time in history, regardless of HIV. And if we look at the costs that are associated with multimorbidity, this is from a very large study in California recently published, you can see that the average cost for a person with HIV without multimorbidity is around $30,000 at the bottom left. But as you increase the number of illnesses a person has, you add to HIV 1, 2, 3, 4, whatever number of comorbidities, you can see the rapidly escalating cost of managing the health of these individuals. The reality is that if all of us live long enough, we'll all have a number of comorbidities that are associated with aging. But the costs are extreme, and they are largely associated with medication. Next slide, please. So there is one primary risk for multimorbidity in older adults with HIV. One. Can you guess what it is? It's a 3-letter word. Next slide, please, for the answer. It's age. As we age, and particularly as we get into the 5th, 6th, 7th, 8th, 9th decades of life, the likelihood of any person having multimorbidity increases. So it's age that drives this more than anything. And I might mention that age for all of us is largely a determinant of our date of birth, right? When we're reborn. But we know that that's really kind of inaccurate in many ways, because there are some people who age rapidly and some people age slowly. Classic example. Oh, my mother, who is 85, looks like she's going on 50. Though we hear that often, but that's not true of everyone. There are people in their 50s who look like they should be 80, at least visually. So aging is a highly variable phenomenon, and it is not tied to your birth date. The birth date is rather inaccurate. But until we have a better measure of aging, and scientists are working on it, we're not going to really know what your real age is as regards to your biology and your status at any given moment in time. So your DOB is what we have to go with, but it's not the best measure. Next slide, please. Now, in this slide, I'm showing you this slide for two reasons. One, this is a look at a fairly large group of patients followed from 2003 to 2013, showing the increase in the number of, or the percent of people who have a certain comorbid illness. In this case, it's cardiovascular events, renal events. It goes all the way up: diabetes, obesity, etc. What's important to note is, number one, as one ages, the number of people who have these disorders increases. As I said, age, okay? The other factor here, and it's really a very important one, let's just focus on the first thing: cardiovascular events, cardiovascular disease. The reality is, in this population, 16% reported a cardiovascular event, but that means that 84% did not. But and you can look at that in almost every one of these categories, that the vast majority, except for hypertension, do not have this disorder, which are associated with aging. The reality is that most older adults living with HIV are doing very well, and some never, ever encounter any one comorbidity. But as people age, they will increase over time. Next slide, please. So this is called the complication of success. Actually, it's a word taken from a title of a scientific journal article. But these are the primary illnesses that are being seen in the HIV population as we move forward. And they are topped by cancer, non-AIDS-related, cardiovascular disease, and then the list goes on: osteoporosis, renal disease, frailty, macular degeneration, hearing loss, etc. This is the result of people living longer, as well as having other risks, which we're going to go into in a second with HIV. Next slide, please. So the question is, why is this happening? And the central culprit, if you will, identified by most researchers and clinicians, is the inflammatory response that we all experience as we live and as we get older. And for those who have HIV, there is an increased inflammation in the body at the time of infection, and that inflammation continues throughout the lifespan of the individual and is only blunted by taking anti-HIV meds. So the inflammatory response associated with HIV is persistent, it's there, it's only blunted with HIV drugs, and it cannot be eliminated. So think about this for 1 second. HIV contributes to the inflammatory cascade, but there are many other risk factors that are not specifically HIV. And for those people who are suppressed and taking their HIV meds, they have an inflammatory response that continues, although considerably reduced. And if they stop taking their medication, that inflammatory response increases again, and it goes away again when someone takes their meds again. So for people, for example, long-term survivors who've taken their meds over a 20-plus year span, no one is consistently taking their meds every single day. No one does that. But for those who take a break for a day, a week, okay, or are in the process of changing the meds because a certain regimen is no longer effective, viral load goes up again, and with that come an increase in the inflammatory response in the body. Next slide, please. So whether you have HIV or not, and this is a cover article from Time magazine, has nothing to do with HIV, but every one of the categories or comorbidities that are listed here, and there are more, are all seen to be occurring because of increased inflammation in the body as a whole. Now, I could talk about the inflammatory response cascades from now and probably until next Sunday, a week from Sunday, and we still wouldn't be finished. So we're not going to go into that detail here, but the reality is that if we can reduce those things that induce inflammation, we can predict a better outcome. Next slide, please. we know that in the HIV population today, there is an increased number of comorbid conditions, namely multimorbidity occurring. And we know that with increased burden of disease or increased number of comorbid illnesses, that stressor, okay, continues to increase inflammatory response in the body. So keep that in mind. Next slide, please. So this is a list of the risks that are operative in causing inflammation in the body. You can hit the mouse again, the list will come up. So the list is long, and we're going to look at it again. At the top of that list is smoking. Smoking is one of the most significant contributors to inflammation in the body. And for those who are living with HIV, we know that compared to the general population, they smoke at least 2, 3, 4, 5 times the rate of smoking we see in the normal population or typical. This is, if you wanted to take care of one risk factor and reduce the likelihood of more comorbidities or reduce the severity of them, it's to stop smoking. The list here is, some of them are obvious. Substance use. We know that there is a large history of substance use in this population, and we know that some continue to use substances. That includes alcohol. As a matter of fact, for the older adult, alcohol is the drug of choice, if you will. And yet we know from recent literature now that even the moderate drinking, 2, 3 glasses of wine per day, is too many. Now, this is not to say if you're out socially and you want to have a glass of wine, yes, do it. But the reality is that even low levels of alcohol use are not good, and they can lead to greater numbers of not only comorbidities, but severity. We also know that this population is not eating well. They have little or no exercise regimens in their lives. Many are co-infected with Hep C. Hep C is Hep C is cured. There are after effects of having had that viral infection. We also know that stress, any kind of stress from depression, stress from issues within your life, your family, whatever, contribute to increased inflammatory response in the body. Another is social isolation. As a matter of fact, in a huge study of 5 million people across the world globe who were older, over age 65, people were asked, what is it that made the biggest difference in your life? And yes, not smoking, eating well, exercise, they were all there. But the number one thing on the top of the list was maintaining and developing new human relationships. And that did not include the number of people on your Facebook page. And I'm being serious about that. You need to have functional face-to-face relationships. And social isolation is something that is endemic in this population. When we ask in our research, what is your greatest need, without prompting them, social isolation is at the top of the ladder. So if you're not eating well, obesity issues will prompt in, particularly in females. And we know that obesity is also somehow, not knowing how, associated with cognitive issues. And social isolation, like loneliness, is toxic. And we know, of course, that many people isolate because of stigma. Stigma is alive and well in this epidemic in this country and across the world. How we combat it is also a challenge. We talk about it, but how do we change it? Especially for the person living with HIV, there are no known interventions, at least to my knowledge. Next slide, please. By the way, that stick figure there, the median age today of the older adult population with HIV is around 59 to 60, not even a senior yet. So patient factors, these are factors that we can look at to change, if you will, or perhaps change in order to reduce inflammation. There are things that we cannot change. Once again, age, sex, male, female, or any genetic predispositions that we bring to the table. These are unmovable feasts, if you will. But things that can be changed are, and these are some examples in the right column, are your weight because of diet, smoking, alcohol use, illicit drug use, exercise. If you want to do something that really, really can reduce inflammatory response or moderate it in your body, and I'm not talking about walking, I'm talking about a resistance exercise, be it free weights, machines, or even stretch pulleys. This one thing, after if you're smoking, it will significantly improve your health. And there are a whole host of reasons why, but during exercise, human growth hormone is released, cortisol levels are decreased. In each case, they affect the inflammatory cascade. And of course, always, always, always adherence to your HIV meds and every other med. Next slide, please. So stress, it's hard to believe that stress, okay, causes inflammation in the body, but in fact it does. And when I say stress, it could be anxiety because of something, event in your life or events. For those people who are depressed, you are under a stressor situation or have depression, anxiety, or another mental illness diagnosis. I remember when I began work with populations of HIV back in Phoenix in 1994, if someone came in the office and they had a new diagnosis, the first thing we'd say is you've got to get rid of every person in your life that causes stress, because stress impacts the immune system and causes inflammation. Next slide, please. So this is just to look specifically at some of the risk factors that we mentioned, but look at just cigarette smoke. And again, I said before, in New York City, for example, in most cities, the average rate of smoking is about 13%. When we look at the older adult population in this city and others, it's around 50+%. Actually, in New York, it's around 57%. It's a very large number of people smoking. And the impact on health at every level is considerable. As you can see, smokers with HIV were almost twice as likely to die than non-smokers, and smokers with HIV were almost 6 to 7 times greater likelihood of a cardiovascular event. And the list goes on, including for cancers. If you know of anyone, you've got to engage smoking cessation programs, whatever they might be. And most states offer them, but it depends on your locality, and you need support from one another in doing this. Next slide, please. These are the numbers about the number of people who smoke. Next slide, please. If there's any one risk factor that we know a lot about, it's smoking. Here too, once again, this reiterates the high risk for people with HIV and smoking. That includes, by the way, secondhand smoke, which is actually more injurious than primary smoking. Next slide, please. Substance use. Tobacco is a substance, by the way. Here is from our study, research on older adults back in 2006. We looked at people who were older adults who were presently using a substance and lifetime use. And what this data tells us is that, in fact, alcohol becomes the substance of choice for the older adult, which is a lot driven by access and by economics. On the other hand, in a lot of interviews we're doing with mental health providers across the country, we know that older adults, particularly MSM, are reverting back to the use of recreational drugs. And that's happening because that is their entree back into the social milieu, if you will, of younger MSM. So is that a good thing? No, obviously not. So we are concerned about that, and we need to provide support so that doesn't happen. Next slide, please. Here is the data on the alcohol. Actually, the best study is a very large study just published last year from the VA on, I think, about 40,000 HIV patients. And they showed very clearly that alcohol use, particularly high levels, of course, can reduce CD4 count. And CD4 count tells us about the functioning of the immune system. So an occasional drink, sure, but persistent daily use. Next slide, please. This is a look at cardiovascular disease and diet. You know, the best measure of diet is all things in moderation. So, but it also means exercise and eating small portions, etc. The guidelines are multiple, but you need to change lifestyle. And I know there are also economic issues here because many people with HIV are seeking food and have little available in many places in this country. A sad commentary. Next slide, please. This gets to the point I was just making. It costs about $25,000 to $30,000 a year to treat HIV by medication. The cure for Hep C is around $80,000 to $100,000 one shot. However, the cost of food is rather low, $6,000 a year as estimated by the government. And yet this is the one area where the HIV patient with HIV who's older is facing challenges. It should not be the case. Next slide, please. Another risk factor are your social networks. Very often we think that our physical health, be it all these comorbidities and the development of them and their severity of them, can be treated with pills. You've got to understand that all medical health issues are not treated with pills. We know that if a client or patient goes to see their physician in the USA and they walk out of that office without a prescription, the doctor fails. Well, that's not true, and you've got to know that that's not true. And the amount of money we spend on OTC, over-the-counter drugs, tells us that we are really a society hooked on pills versus any other society in Europe or other parts of North America. We need to pull back from the belief that pills solve all issues. They do not, especially complex health issues. Now, in the case of HIV, absolutely. But in some cases, it's not just the pill that you need. In fact, very often, you know, for every pill you put in your body, there's a price being paid somewhere along the line. So think about that. And this is also the function of preventive health, which, by the way, doesn't exist in this country. We only take care of things when the plane falls out of the sky. Next slide, please. So I want to just emphasize the issue of social isolation, which is driven by depression and stigma. In our study, and now many, since we did this back in 2007-9, we showed that 70%, 70, of the HIV population older live alone. Now, many young people live alone, so they have a partner, get married, whatever, particularly MSM groups. But this is the antithesis. For example, in New York City, only about 39% live alone, okay? But 70% is a number we've seen over and over and over again in literature. Next slide, please. The reality is that living alone, loneliness, is associated with stress. So here's another piece of data that's very telling. The number of older adults in our research, and again, other research bears this out, only about 15% have a partner, a spouse, or however you want to define that, a constant partner. It's a very, very, very low number. And we'll see in a second why that's important. Next slide, please. How many have children? Okay. Again, a very low number, less than 20%. You know, the outside world, next slide, please. The outside world looking in often thinks that because of advances in gay rights especially, that everyone who's MSM is going out and getting married and having children. This is not the case. This is not the case, particularly in this population. So here is data directly measuring depression or the symptoms of depression. And we found, as have others, that about 43% have severe depression and another 20% have moderate depression. This is as measured by the CESD tool. This varies, okay, by where you measure it and how many. But the reality is that people living with HIV who are older have nominally 5 times the level of depression we see in the outer society. And what's even more disturbing about this is that the number or the rate of depression in the 80s and today is not different. You know, in the 80s, we might understand it because there was no cure and depression would be expected. But today, there is treatment that will sustain a person through a normal lifespan. And yet, the levels of depression remain high. And depression causes an increase in cortisol in the body, which drives inflammation. So depression should be treated, and it has not been in this population. Next slide, please. Why is depression important? I mentioned why a treatment of it in regards to inflammation, but also it is the single best predictor of non-adherence, not only to HIV drugs, but also to all other medications. As a professor in psychiatry and neurology at Columbia Medical for 25 years, I know that depression is eminently treatable, but in this population, it has not been treated or managed well at all. There are many ways to manage depression. It need not be pills. It could be verbal therapy. It could even be, listen to my words, socialization. ACRIA conducted a study based on the MacArthur model where we called people who we knew were depressed by screen once a week for 5 minutes for 6 months. And in the first 3 months, their depression scales dropped significantly. But what was even more telling in that study was that a number of people, many, were on antidepressants. So think about it. We find people who are depressed on antidepressants, and when we talk to them on the phone, no therapy, just say hello. I always mention the hello in there song by Bette Midler. Their depression went away. A 5-minute phone call. Think about it. This speaks to how, if social isolation could be addressed, I think the issues of depression could be resolved, many of them, and we would have better adherence to medication across the board and better health. Next slide, please. All right. Do we have to do this now? Can we have the next slide? Okay, next slide, please. As I mentioned, depression can be managed in many ways, and there is no reason why not. Next slide, please. So many have come to the conclusion that management of multimorbidity is the domain of geriatric medicine, and in fact it is. It's what geriatricians have been doing for a long time now. Is there a good way to do it, a bad way to do it? Those are highly variable. There are many models, but there's some basic principles so that the HIV treating physician, you can think about this. We've had conversations with long-term HIV treating docs. They signed up to treat HIV and AIDS. That's what, when they were largely younger physicians, they decided to go into this world. Many are ID docs. But when it comes along that they have to deal with cardiac issues, kidney issues, osteoporosis, Hep C, etc., that's not why they signed up. Okay? It's not meaning that they can't manage it, but that's not where their training comes from. So the geriatrician is in very well placed to manage multimorbidity. And Why? You can see that their way of approaching health is very different. The dominant goal of a geriatrician is to maintain function, independence, not to cure diseases or even manage all of them. They also know, geriatricians know more than any physician I've ever spoken to, the need for social support. These are the social networks that I've been alluding to. The caregivers, if anyone's taking care of a parent, a friend, a spouse who is ill or aging, it's that care, that informal care that aging experts know is essential to a very good aging process. But we know that the person with HIV does not have good social support, does not have a good social network. So we are very concerned about that, and we need to change it. Also, geriatricians listen to their patients if they're sentient. They don't just tell the patient what to do, they tell the patient why they're recommending it, and if the patient has an objection or doesn't want to take another pill, they listen. They're also very concerned about polypharmacy. The more pills you add to any regimen, that includes over-the-counter pills, the more likelihood of your encountering an adverse reaction. And sometimes some of those adverse effects are unknown because they're not in the literature. You know, older adults are a very small part of the population, at least now, and most standards of care were established on people from 30 to say 55 years old, not on older adults. And lastly, one of the most important tenets of geriatric care is integrated healthcare. How many times have I heard patients tell me, my doctor sent me to a specialist, cardiologist, a rheumatologist, whatever. And the patient goes, maybe gets meds, is put on some treatment, but no one speaks to each other, meaning the physicians. And this is dangerous territory for the patient, absolutely. So the patient is usually the one who has to insist that the doctors talk to each other, or nurses or whatever, but they don't. Integrating care is absolutely essential, and I'm not sure how to achieve that, but there are movements afoot to change our medical that does. Next slide, please. Coming close to an end here. Next slide, please. By the way, there are many studies. We're part of one at Cornell, ACRIA, and others are in San Francisco with Dr. Meredith Green. It's curious that when a geriatrician is called in to do a consult on an HIV older adult, they make recommendations, right? Those recommendations are maybe a third of them are followed by the primary care physician. So one of the things that we're asked in North America and Europe was, what is it that provides good health from your perspective? And you look at these, some of them are expected, okay, you get good care. But there's also at the bottom of the list, effective coordination. And of course, the continuity of care. There's nothing worse than going from one physician to another and having to re-explain everything that's going on. It should have been, because of ACA, improved electronic health records, but we've yet to see that day here. Next slide, please. Next slide, please. I'm going to skip this slide, but the pill burden that exists in this population because of HIV, and add on to it the comorbidities of aging that are occurring, the pill burden is huge, and it must be reduced, and there are ways of reducing it. If you look at this slide, they're just practical hints that you and your physician need to engage in. Next slide, please. I've just reviewed a couple of papers for scientific journals which show that as the number of pills increases in the older population with HIV, the adherence to the HIV meds goes down. They tend to adhere to the newer medications more. Not a good thing. This is polypharmacy. Polypharmacy are untoward or interactions that occur among drugs. Some can be predicted, but you can see here the level of high incidence of untoward interactions is considerable, up to 1/3. But the only person usually aware of this mostly are pharmacists. Next slide, please. Click the mouse again. This slide is here to show you, again, the increase in these multimorbidity issues. The one that doesn't change is depression. Next slide, please. I can't emphasize enough the need to reduce stress in your life. The health outcome of it is extraordinary by all data that we see. Next slide, please. Next slide. So ACRIA, with the American Academy of HIV Medicine and American Geriatric Society, about 8 years ago, got together a group of experts to look at how one might best treat the older adults. There are no standards of care for treating older adults, even for geriatricians who don't treat HIV, which there are maybe 2 or 3. The standards of care are based on, again, on younger patients. There aren't enough patients who are older to develop a standard of care. And it's for this reason that a geriatrician, for example, will start at the very lowest dose when they give a new drug to a patient. But a series of guidelines, actually 25, came out of this effort. You can go to the site. You don't have to register. It's for everyone, and it's quite accessible. When we started this back about 5 years ago, there were no visits. Today, we have between 5,000 and 6,000 visits per month. So the interest and the need for guidance, if you will, some suggestions, rest on this site. Next slide, please. So from this site, from the recommendations, we took them all together and we rewrote them for the patient. Even though the clinical language on the site is actually fairly accessible, but we rewrote a booklet which was rewritten by all of us, and as well as one of my staff members, Mark Milano at ACRIA, now GNHC, to bring it to a language that was accessible. And what this document does, we've actually distributed 65,000 of them. You can download it online. It tells the patient what they should be aware of, what they should ask their doctor, and what they can do to improve their health as regards to any of those comorbidities that we mentioned earlier in this presentation. It's a very, very valuable book, and it's also available in Spanish. And we're very happy that there's a woman on the cover. Next slide, please. So this is my last slide, and really it talks about the integration of care, the need for somebody, it might be the patient, or some organizer, or someone within the medical care system that's watching all these treatments and interventions that are going on. Someone needs to coordinate it, and more often than not, it's not happening. And so the risk of all those risks that I mentioned, yes, you can address them, and some will be addressed. There needs to be a dialogue between the primary care doctor and all other specialists, no matter what the discipline. If you don't do that, that's a risk unto itself for increasing multimorbidity. I think it's the next and last slide. Next, here we are. It is. Yeah, thank you, and I'm sorry for the difficulties, but we got through this. And if there are any other questions or you want to send me an email, please don't hesitate to do that. Thank you so much. I'm not sure if we're going to take any Q&A here. Please advise.